Good afternoon, everyone. It is 12 o'clock on the dot, and after a slightly premature entry where you got to see a little bit of the sausage making, those of you who arrived a bit early, we are very grateful for you all for joining us today. I'm Dr. Kim Newell Green, and I'll be the moderator for today's virtual Grand Rounds, the National COVID-19 Surge and Hope for 2021. A conversation with state leaders and members of President-elect Joe Biden's coronavirus task force. Next slide, please. You can please note here our speakers' disclosures, and also that, as usual, CME is being provided. Next slide, please. These are our speakers. Next slide, please. And here are our learning objectives for this webinar. After this webinar, we hope that you'll be able to address physician wellness in the COVID-19 pandemic, address co-infection risks and testing strategies during the winter respiratory virus season, and discuss national and state strategies during the coronavirus surge. You will be sent a survey after the completion of this webinar where you can attest your attendance, and upon completion of that survey, we'll send you your certificates. So this marks 6 months of our COVID clinical grand rounds sponsored by the California Health and Human Services and the California Medical Association. And it's been a wonderful opportunity to bring cutting edge clinical, epidemiological, public health information to physicians, physician's assistants, nurse practitioners, and many others in California and elsewhere. We have just entered a phase in our response to the COVID-19, a new phase in response to the COVID-19 pandemic in California, a lockdown in the face of rapidly advancing third surge. Upcoming holidays that are so important to many of us will look very different this year. And I'm sure that many of you all who are engaging in clinical responses to this pandemic while juggling more home responsibilities and perhaps navigating distance learning with your children are ready for a long winter's nap. And yet, there is a sense of hope, a light ahead. We entered the new year with several vaccines in hand and the prospect of immunity and also a new administration in Washington, D.C. Today, we are thrilled to have with us Dr. Seema Jain from the California Department of Public Health, who was previously at the Centers for Disease Control and is an expert on viral co-infections. Dr. Jain will give us an update on the state of the surge, help us understand what we know about winter respiratory virus season and how that may evolve and complicate our response to the COVID-19 pandemic this winter. Dr. Erica Pan, our acting state public health officer and state epidemiologist and a frequent guest on this series, will give us an update on the planned vaccine rollout. Following that, we're incredibly grateful that 2 of the members of President-elect Biden's coronavirus task force have given us some of their precious time today to talk about what they bring to the task force and share with us some of the thoughts about next steps and hope ahead. Dr. Robert Rodriguez, an emergency room doctor who has spent significant time during this pandemic in his hometown of Brownsville, Texas, not only providing care to, but also bringing public attention to the plight of some of the most vulnerable and most affected during this pandemic, has also developed an interest and expertise in the wellness of our care providers during this stressful time, and he will discuss his work. Finally, we'll hear from Dr. Eric Guzby, an infectious disease doctor who spent many years working in HIV/AIDS at the University of California, San Francisco, and also has robust experience in public service, having worked at the federal level in many administrations since the 1990s. Among other positions, Dr. Guzby was the U.S. Global AIDS Coordinator, and more recently has been the Special Envoy on Tuberculosis for the United Nations. He certainly brings a depth of experience in navigating disease control at the federal and the global level to this task force. And so without further ado, let's hear from this distinguished panel of speakers. Please submit any questions you have throughout the presentation by using the question box in the control panel located at the right-hand side of your screen. We'll go over the questions at the end of the presentation. Now I'd like to turn the time over to Dr. Seema Jain, Chief Disease Investigation Section for the Infectious Diseases Branch at the California Department of Public Health.
Good afternoon, everybody. Thank you for the opportunity to speak with this incredible group of people. It's my pleasure to be here. Next slide, please. Very briefly, I'm not going to go over this slide in a lot of detail, but as we all know, coronaviruses are something we've seen before and also of zoonotic potential. Next slide, please. I did want to stop on this slide and just kind of frame this conversation around our two previous viruses that folks should be really familiar with, SARS and MERS, and really wanted to point out when you look at the number of cases here and deaths that we far exceeded this globally with COVID-19. However, the case fatality ratios for both SARS and MERS were quite high comparatively to what we are seeing with COVID-19. And then finally, that both SARS and MERS were not primarily healthcare associated or viruses where a lot of transmission was happening in that sphere, which is also really different than what we see with COVID-19. Next slide, please. So where were we at the start of this year? And I think this is a good time to kind of see what the year has been like. You know, on January 22nd in the United States, we had known there was a novel coronavirus that was associated with the pneumonia cluster in Wuhan, China. And this virus was sequenced on January 10th. The first case was exported to Thailand on January 13th. And we had our first US case on January 21st and our first one in California on January 22nd. At that time, there were already 600 cases reported associated with the Wuhan outbreak. Next slide. And I think many of us are familiar with this website from Hopkins, where many of us were looking at it moment by moment early in this pandemic. And of note, on March 9th, we only had 566 cases in the United States. Next slide. And a lot of this was because, you know, we had a really different way of testing in the beginning. There was very scarce supplies with testing. Only certain people could be tested. All the testing was allocated by CDC. And if you remember that PUI criteria, as many clinicians will, it also required that you had travel from geographically affected areas. And so again, my point of bringing all this up and reminding us of where we started is, next slide, of where we really kind of want to go and really trying to emphasize that testing is actually a very core part of surveillance. So surveillance, just for folks to understand from a public health perspective, is a core function that we aim to use to guide public health action. We require systematic data collection, analysis, interpretation, and timely dissemination, which is essential to monitor pandemics such as this, including direct and indirect effects, to use these data to prevent and control transmission of infectious diseases and their sequelae, and to understand why these infections are happening that can then therefore inform public health action. And then finally, but not least importantly, is to identify and eliminate health inequities and disparities to improve overall public health. And I won't be able to go into all of these today, and really will be focusing on the first one. Wanted to remind and center how we view the pandemic at the state level. Next slide. So today I'll really primarily be talking about the direct effects of COVID-19, so cases, hospitalizations, ICUs, deaths, and complications. But I do think it's important to remind everybody of all those indirect effects that are harder to really gauge and ascertain, including discrimination, loss of employment, loss of economic stability, other healthcare, and also mental health, and to remind us that these are all actually intertwined. Next slide. This is sort of a typical disease burden pyramid that many in public health and infectious disease really think about. And my point of bringing it up here is that there's really hard with only one system to be able to really ascertain each pieces of the triangle. So really often we need several systems to help answer questions about disease burden and be able to monitor pandemics through time. What we really want to be able to understand is asymptomatic infection, symptomatic infection, that which is medically attended or outpatient, hospitalized, and also death. Next slide. So this is, I had the pleasure of doing a talk like this about a month and a half ago, so mid-October, and this is what our epi curve looked like at the time. So for those of you not familiar, on the x-axis here is episode date or illness onset, and the y-axis is number of cases. So this is what we look like on October 22nd. Next slide. And this is what we look like as of yesterday. So as you can see, we have a very large second wave that we are in the middle of right now. We're not really sure when it will peak, but this is where we're at the moment. Next slide. This is now looking at the same thing, except now for deaths and not cases. And this is where we were on October 22nd. Next slide. And this is where we are now, basically coming to a third hump of deaths that are occurring in this pandemic. Next slide. And again, I should remind everybody, these are all California data. This is one way that we look at our cases, hospitalizations, and deaths over time to make sure that there's not anything really changing. And really, the bottom line of this slide is that most of our deaths are happening in the elderly. 40% are actually happening in those that are 80 or above. Our hospitalizations are in the younger elderly. And then our cases are, typically in the middle-aged group. And this is something we've been monitoring over time, but you can see that in the beginning of the pandemic, it was a little bit different in the most severely ill that were hospitalized were being tested. Next slide. This is a slide that actually puts cases in blue and deaths in red and hospitalizations in orange and ICUs in black here all in one slide to really indicate that after you see a peak of cases, usually about 2 weeks later, you can see a peak of hospitalizations. And then a couple of weeks later, you start seeing increases in deaths. These are data that we've been looking at really carefully that have really been informing our non-pharmaceutical interventions, including stay-at-home orders, closures of bars, and other things that Dr. Pan might be able to go into more detail about. Next slide. I did want to put a plug in that we have a website called CalCat. You can just Google it. And in this, we actually have modeling data that shows are effective or ways that we look at transmission that's occurring. You can look at this at the state level, but then also at the county and regional level as well. And this is basically indicating that transmission is continuing at the moment and stable. Next slide. In addition, we have on this modeling website hospitalizations data and forecasting, and we're using these data to make decisions about policy, et cetera, as there's a huge concern for both bed capacity at the hospital level and also at the ICU level, clearly at the moment. Next slide. So a couple of just ways to look at the data and things that hopefully folks have seen before, but this is just looking at incidence over time in different age groups. And the bottom line of this slide is that you can see in the purple that our incidence in California at this point has peaked in the month of November beyond what we've seen before. And this is true for every age group. Next slide. For the pediatricians out there, this is also true for all the different children age groups as well, depending on if you're a pediatrician till age 21. This just breaks it down again, showing that we've really peaked in our incidence right now, or are peaking. Next slide. When you look at these same incidence data or case data by race and ethnicity, what this slide is showing, and there's a lot of colors, it's a little busy, so sorry about that. But on the x-axis, you have different racial and ethnic groups, and on the y-axis, you have incidence per 100,000. What this is showing, I think, first and foremost, is that in November, in every group, we've actually peaked again, and no group is spared as we were in July. However, you can also see that there are different patterns of disparities. Throughout this pandemic, Latinos and Native Hawaiian Pacific Islanders have had higher rates of illness. However, now in this particular peak, we're also seeing higher rates in whites than we have before, in Asians than we have before, American Indians, and African Americans as well. One of the things we're looking at is to see if some of those can be due to testing practices as well. Next slide. So when we look at mortality rates or death rates, again, over time, so these are 4 different bar graphs looking at age and looking at mortality rates over time, I think by and far, I think all of us understand that the deaths are really occurring in those who are 50 plus, and particularly in those 65 and older, and even more so in those who are 80 and over. And you can see this pretty consistently over time. Next slide. And then when you look at deaths by race and ethnicity, and again, you have race and ethnicity here on the x-axis and mortality rates per 100,000 on the y-axis, you see disparities again. One that you can't quite see the November and December data yet, because again, deaths lag and take some time to show up. But you can clearly see that our death rates in African Americans, in Latinos, in Native Hawaiian and Pacific Islander are really disparate with their population overall in California. I think one thing I wanted to mention about this is that given all of that, there has been several efforts on the ground to work with community-based organizations and other groups to really try to make a dent in these disparities. In addition, a lot of the data that we've shown here related to race and ethnicity have also led to a health equity metric that you can also see on our blueprint online as well, and is informing both the way we do surveillance and then also public health interventions as well. Next slide. Again, for the pediatricians, I wanted to just make sure folks knew that we are doing surveillance also on MIS-C cases. We do have, I think, a lot of reporting from Southern California, but an increased reporting from the Bay Area. One of the important parts of looking at these data is that in general, as community transmission is increasing, we generally will see also then a subsequent increase in MIS-C cases. So we're starting to see a little bit of that now based on increased rates earlier this fall. Next slide. A few other ways that we look at the data are looking at things that perhaps folks may not be as familiar with, but you may have gotten familiar with it as if you've been looking at any blueprint data. And this is called test positivity. So this slide in the red line is showing test positivity over time, and the green and the blue bars are testing volume. I think the bottom line point of this graph is to show that in the last 5 weeks or so, our testing positivity has doubled, and this is in the setting of having much more testing volume. At this point in the state, we run about 250,000 to 300,000 PCR tests a day, so that does not include antigen tests. Next slide. And this percent positivity that you see, this increase, you can see really in every age group and also in every geographic region in the state. Next slide. So I did want to spend a minute or two on co-infections and other viruses, which is sort of my area of fun and interest. I probably won't have as much time to go into as much detail as I'd like to. But I think one of the things I wanted folks to know is that we do have an ILI system at the state called the influenza-like illness system, which really focuses on mild illness. And in this system, we can see here in the black line that our syndromic influenza-like illness, which is cough and fever and or sore throat, is what we consider to be at seasonal baseline, which is 2%. And then you can see in the different colors, different pathogens that are circulating. In red is COVID, and you can clearly see that there's an uptick in the red. But at the same time, you can also see that there's a light blue line, which indicates that rhinoenteroviruses or cold viruses are commonly circulating, which is true for what we would see at this time of year. Next slide. I did want folks to remember that we have obviously have influenza as well. It's been very low so far, and this may or may not be related to other non-pharmaceutical interventions that have occurred. Next slide. But right now, our rates of influenza virologically are much lower than we have seen in previous years. That being said, there are, heterogeneous results globally for what kinds of influenza viruses have been circulating in different areas of the world. Next slide. Please do make sure to take a look at our website where you can stay updated on all the different influenza-related surveillance that we have, which includes deaths, outbreaks, laboratory data, hospitalizations, and also outpatient influenza-like illness. Next slide. And then I wanted to take 1 minute to just talk about a special project that we're looking at, where we're trying to enroll patients in a Sentinel community surveillance system. We currently have 9 counties and 3 more that are onboarding. So some of your institutions may be involved. Next slide. Next slide. And in this, what we do is not only test for SARS-CoV-2 and also influenza, but we are also doing a panel of other respiratory pathogens, including mycoplasma, at the state laboratory. Thus far, we've actually found about 8% of other pathogens that are not SARS-CoV-2 in this Sentinel surveillance system, and 8 co-infections. So our data are convenient and Sentinel, but they do provide some signals as to other things that are going on. Next slide. So this is just a slide really highlighting that the vast majority of other things that are circulating are rhinoenteroviruses, which, you know, clinically we don't always test for, but there is a smattering of other pathogens as well. And the co-infections, next slide, are depicted here in bold black, and you can see that the vast majority are COVID-2 and rhinoenterovirus co-infections so far. We haven't seen influenza yet in this particular system, but we are testing for it. So far, the other co-infection we've seen is with parainfluenza virus and also one with mycoplasma. In those 8 cases, none of those were more severely ill than anyone else, as one would probably expect with rhinovirus and enterovirus circulation. Next slide. And then finally, just really to summarize, because there are other great speakers on today's panel, is just a reminder that surveillance is a core public health function that we are using every day to make decisions. There are a lot of different pieces of surveillance I wasn't able to touch on, but looking at all of these things is going to help us really understand what the burden of disease is. We do think that these data could be used when talking to patients. I know I do with my patients, talk about COVID and other pathogens, and help remind folks about the non-pharmaceutical interventions that we have at hand right now. Clearly, during this holiday season, it's going to be important to remind folks to stay put, be safe, you know, order your groceries, and take every opportunity to talk to your patients. And luckily for us, Dr. Pond is going to talk to us about all the vaccines that are coming down the line. So that's it, and thank you for your time.
Thank you so much, Dr. Jane. Really great to have such an expert with us today. Now we are pleased to hear a few words from Dr. Erica Pond. As I mentioned before, Erica is our California State epidemiologist, and she's a deputy director at the CDPH in the Center for Infectious Diseases. Thank you, Dr. Pond.
Great, thanks so much. Nice to see you, Dr. Green. And yeah, why don't we keep moving? I'll try to keep this quick. I think you all have gotten a little bit of information from various speakers in the past about vaccine planning, and I thought today I would talk a little bit more about the nitty-gritty, because a lot of people have been having questions about that, amongst other things. And there's a lot of other vaccine experts out there that can talk to you about the specific vaccines. But you know, as Dr. Jane just mentioned, we are. It is really nice to have a light at the end of the tunnel. We know the tunnel is still long, but at least we can see it. So hope is definitely on the horizon. We're really working very actively to accelerate our planning, and some key values we really continue to hold for vaccine planning is safety, equity, and transparency. So we're working on that. Next slide. And just some overall goals of our vaccine planning, again, are, you know, looking at efficacy and safety. We have a community vaccine advisory committee that has now met at least twice, possibly 3 now. I'm already losing track, but a really broad group of stakeholders to provide input onto all of our planning and make sure we're really thinking about, again, our 3 core values, as well as getting broad stakeholder input. And we have a prioritization framework allocation plan, which we have a drafting guidelines group working on, and then they bring that to the Community Vaccine Advisory Committee, who provides input, and there's some great sort of exchange and dialogue between those two, and then those committees bring that information to us at the administration, both the Health Department, the Health and Human Services Agency, and we then in turn inform the governor on how we are rolling out all of these things. Then what I'll focus on today is distributing and vaccinating once the vaccines are available. and making sure, again, that we have some equitable allocation. And then a big, huge focus is communication and really further ramping that up. In fact, right now we're getting some results. Some of our team is getting some results from surveys of people like you, healthcare workers, since you are in that first priority group, which I'll move towards. But one of our most important and biggest concerns is vaccine acceptance. So we know, and many of you have seen polls that say only 50 to 60% of the population right now are actually saying that they would take vaccine if it were available to them right now. And we can get all the logistics right, but if people are not going to accept the vaccine, then that would be a huge problem. So that's the other reason we actually did develop a scientific safety work group as well, with a lot of our national and state experts, and actually Dr. Gooseby, we were fortunate enough to have him on that work group as well, and other nationally recognized experts. So that group is also just really making sure that they can reassure us in California that none of the steps were skipped for the normal authorizations. Yes, this has been an amazing year of technology and moving forward vaccines, which we've never seen happen at this speed. So we want some reassurance from our experts that no steps were skipped along that way. They were just moved forward in a quick way. So that's the goals of that. And it will not, our intention is it will not delay any distribution in California. Next slide. So really quickly, Governor Newsom presented a lot of these on the press conference yesterday, but I thought it was sort of nice to really just walk through again the steps of how it actually works. And much of it is, the other emphasis I would say to all of you as healthcare providers is really we still intend, especially at this stage and multiple stages when there aren't as many vaccines, that it is going through our normal infrastructure and going through healthcare providers for the most part. So early on, and I'll talk about numbers in a little bit, we're not planning, and local health departments are not planning mass vaccination clinics necessarily at this point, because it is sort of trickling in here in the beginning. But all the things that have to happen behind the scenes are that many of you may know as well that as providers or your provider systems have to enroll in our special system and do training for that, and making sure you can reassure us that you can do the storage and administrative capabilities to store a vaccine, looking at our prioritization guidance and which populations are prioritized. And as our drafting guidelines work group develops those and they get approved and reviewed by the advisory committee and our state sort of administration, then those are put into there. And then at the local health department level, that's when the vaccines are allocated to the enrolled providers according to this guidance. And then the orders are approved and they forward them back to us for processing. Next slide. And then we look at those, we submit those to the CDC. Next slide. And then the CDC looks at those and they submit orders to the manufacturers. Next slide. So then the orders are fulfilled and they're processed for shipment. So of the two that we think are very likely to be approved at any within the next week, Pfizer does its own distribution and does its own shipping, and Moderna is using McKesson as a distributor. So then it gets shipped from these distribution centers directly to California providers. Next up, next slide. So the vaccine is transported from the factory to the providers. There's not like a state warehouse that we're keeping them in between for these steps right now. And of course, the really biggest challenge right now with the Pfizer vaccine is the cold chain requirements and that ultra low temperature that need to be maintained during transport, and of course, once they get to their destination, to preserve how long you can use them. Next slide. So then, as providers, you will receive the vaccine, and you, again, need to be storing at least the Pfizer at the ultra-low temperatures. The Moderna is more routine temperatures, and then that's when you can administer it to your patients, or actually not your patients. It's primarily, again, healthcare workers and healthcare systems, and I'll talk about Tier 1 in a slide or two. And this is just a picture of one of the ultra-low freezers that we've purchased to be across the state. Next slide. Oh, more pictures of that. Next one. And this is just to tell you, and some of you may have seen this in various other vaccine talks, including any that we from the health department have shared. But again, we're still in this first phase here where we have very limited doses, and targeted administration needs to happen with healthcare providers. And then, as you may know, ACIP in phase 1A also has approved that we vaccinate not only staff at long-term care facilities and skilled nursing facilities, but also the residents, because as we all know, they are at the highest risk and the highest mortality rates are there. So that's this early phase we're in. And then as more doses become available, we're going to have more populations that are we're able to vaccinate, and we're going to need a larger network of providers, and that is where potentially if there are large numbers at once, there might be more mass vaccination clinics and things like that. So we think we're still a couple months away from this at least. And then eventually we'll transition back to where, just like during H1N1, there were some mass vaccination special efforts early on, and now we get seasonal flu vaccines again every year. So eventually it'll return back to being part of our one of many vaccines in a routine schedule. Next slide. So we have submitted our first orders already last Friday, and so we're told we're getting 327,000 doses from Pfizer. We anticipate that will get here next week, and those first doses again are going to facilities that will vaccinate their highest risk healthcare workers. And the facilities that have already been approved and put into that ordering system have plans in place to conduct vaccination. Next slide. And these are the tier 1 categories included in the highest risk healthcare workers. So acute care, psych and correctional facility hospitals, skilled nursing facilities, including the assisted living facilities, other similar congregate settings for older or medically vulnerable, paramedics and first responders, first medical responders, and then actually dialysis centers are in that tier 1. So those are those first allocations. Next slide. And we anticipate that we know that the FDA VRBPAC is approving or is reviewing, I believe today, the Pfizer EUA, and then if that gets approved, then I'm sorry, that's tomorrow, and then the Advisory Committee for Immunization Practices will meet. Is anticipated to meet on Friday. We are anticipating actually that our scientific safety worker will meet on Saturday, and that if all is approved and moves forward, then that would then allow for distribution of the Pfizer. And then similar sequence of events is happening with the Moderna vaccine next week. I will also just put a mention, as there is likely a lot of interest in our vaccine advisory committee and sort of keeping up to speed on how things are going at the state. These are actually public meetings, so you can go to our vaccine website and actually listen in. And starting next week, I think you'll be able to actually visually see as well the advisory committee discussing the different phases and allocation. Our planning assumption overall, so I mentioned sort of our first shipment to give us some concrete numbers, but we think we're getting about 1.1 from Pfizer and I think around 900,000 or so from Moderna by the end of the month. So it's about 2.1 million first doses. Those are first doses, so there's going to be another second shipment. So those are 2.1 million people, and that second dose will come right after that. So this is not, you don't need to cut this in half as you think about how many. We estimate we have about 2.4 million healthcare workers in California. So even with those shipments with both those vaccines by the end of the year, we still wouldn't necessarily be able to vaccinate every single healthcare worker in California. And then again, that does not include the number of long-term care facility residents. So, but we do also, we are being told we'll be getting bi-weekly shipments moving forward if everything continues as planned. So we will continue to get shipments over the months and we'll continue to keep the public up to date on how that's going. Next slide. So, and this is just the COVID-19 landing place for vaccines where you can look for up-to-date information. We actually also have a similar one with more details about each of the committees on our CDPH vaccine website. And with that, I will stop.
Thank you so much, Dr. Pond. It is just always such a pleasure and really a great service to us to be able to hear this super up-to-date information from you. So now I'm just honored to welcome Dr. Robert Rodriguez, a professor of clinical emergency medicine at Zuckerberg San Francisco General Hospital. Dr. Rodriguez, has been mentioned before, is also President-elect Biden's coronavirus task force member. After Dr. Rodriguez's talk, we will have a Q&A before we welcome Dr. Guzbi on, who was available at 1 o'clock. So just as a reminder for any of those of you who might need to leave early, we will post a recording of this webinar on our website, covidroundsca.org, a couple of days from now. With that, thank you so much, Dr. Rodriguez.
Thanks. I want to thank Drs. Newell Green and Dr. Chen and the CMA for having me. It's really a pleasure and an honor to speak with you. As you know, the pandemic has really affected all of medicine. There are particular challenges in all of medicine. And I'm going to discuss addressing one of the challenges, which is addressing the impact of the pandemic on the well-being of providers, healthcare providers, and especially frontline providers across the U.S. This is a big topic. I'm sure you've seen traces of the impact on your providers, on yourselves. And we first noted a lot of anxiety and issues with that in the emergency department in early March, when it started to become an issue, really the end of February. And so we undertook a national study of emergency medicine physicians with 3 goals. The first goal was to assess anxiety levels, burnout, emotional exhaustion, and risk for post-traumatic stress disorder. Second goal was to identify particular stressors in those emergency medicine physicians. And then the third goal was to identify some potential mitigating factors that could be used to mitigate against the stress. And so we conducted our first study it started in the beginning of April. Again, it was a national study with a particular focus here in California. We had 5 sites here in California. And what we found from this first phase of this longitudinal study was that it indeed was having substantial impact on frontline providers, on emergency medicine physicians. Physicians were declared considerable levels of anxiety, high degree of burnout, and risk for post-traumatic stress disorder in as many as 20% of frontline providers by a really well-validated type PTSD risk scale. And so for our first aim, we indeed confirmed that this is a big problem. In terms of our second goal, identifying potential stressors, far and away the number one stressor was PPE at that time. There were shortages of PPE, and really that led to a lot of stress. Second, it was closely followed by concerns about exposing family members to infection, to COVID-19 infection. We had a lot of physicians saying that they changed their behavior at home. They were no longer showing signs of affection with their family members as much. They refrained from hugging and kissing their family members. A lot of them had procedures where they would just like strip down out in their garages and go straight to a shower. A lot of physicians in that early part of the pandemic were in fact just staying away from their family members, sometimes in hotels, sometimes in other places that they could stay. So exposure to their family members was a particular stressor for them. Other type stressors were the lack of testing for patients. Was a particular challenge at that point, still a challenge to be honest. But there were slow testing. Tests were unavailable, and we were having to deal with trying to make this diagnosis in other ways, sometimes by doing CT scans, and it really was made it very stressful to try and deal with this pandemic. Another stressor was the lack of physicians' ability to have themselves tested. So there was a lot of anxiety. A lot of physicians were thinking, you know, oh, maybe I already had it, maybe I have it now. And testing of providers was a real problem. And so that was a particular stressor. So this led to our third goal, which was identifying potential stress mitigation measures. And so understandably, the first mitigation measure was to make sure that we had adequate supplies of PPE for providers. Another stress mitigation measure was to upscale testing, to improve testing in the ER and in clinics. And then a third one was to increase the availability of physicians to get self-tested for COVID-19. And then a final mitigation measure was to basically set up wellness programs, basically resilience type programs for providers that they could go to, have online sessions or other type of sessions to promote well-being and resilience. So that was our first study on this topic. This was a longitudinal study, so we conducted a follow-up study of that in July. And what we found at that point in time was that some of the stressors had changed, and some new stressors arose. The PPE was still a stressor, but it had decreased somewhat because of better supplies of PPE, and but new stressors arose, like sort of the financial impact of the pandemic on their practices, on their on basically having to, in some cases, lay off staff. So the financial impact became a stressor to physicians. A second stressor that became more evident was sort of childcare issues and homeschooling type issues. Physicians again were having to negotiate between work and then childcare and homeschooling type activities. And so that again are identified in our second point in time on that particular study. As we also decided to conduct a more greater national study of this topic, and so I'm collaborating with the CDC, and we just finished a study of frontline providers across the board, and this included nurses, other people in the emergency department, even non-clinical staff in the emergency department. And this study was a 20-site study across the U.S., geographically distributed sites. And what we did in this study was sort of replicate some of the previous aims to assess what particular stressors our healthcare providers are feeling at that point in time. Again, to assess well-being, emotional exhaustion, and burnout, and then again assess the risk for post-traumatic stress disorder. And additionally, we sought to test one of the mitigation measures that we had identified in the former study, and that mitigation measure is a provision of more testing of physicians, both nasal swab type testing, PCR testing, and antibody testing, serum antibody testing. And we found that provision of that measure has a substantial effect on mitigation of anxiety, as physicians were able to know their immunologic status to COVID-19 had that relieved their anxieties to a certain degree. So again, I think that this is a big problem, and the 4 take-home points that I would like to convey are that, number one, the COVID-19 pandemic has had substantial impact on the mental well-being of providers across the board. It's important for you to recognize that in yourselves and in your staff. The second take-home point would be that there are measures that you can do, that you can try and accomplish in your practices, and the first one is provision of adequate PPE. Another one is to increase testing availability of your staff for both nasal swab PCR type testing, acute testing, and antibody testing, and then also to establish programs to promote well-being, resilience, and there are several available freely available here at UCSF and throughout the state. They have several online programs for that, and those are a really good thing to follow. And then finally, final take-home message is that the Biden-Harris team is considering all of these issues, and they're on it. The team is there to support providers across the board, and it's a particular point of emphasis. Thanks.
Thank you so much, Dr. Rodriguez, and really good to hear that the Biden-Harris team is on it, and I'm sure they are much more on it with you there as an expert. So I'd like to invite back on Drs. Pan and Jane, and we're going to do a little Q&A for a few minutes until about 1 o'clock. So since you're here, Dr. Rodriguez, why don't we start with you? Other than the physician wellness, and the healthcare staff wellness, what other priorities will you have, or do you have already, as you work with the Biden-Harris team and think about a evolving national response?
Yeah, I mean, there are so many challenges in all of this. We're particularly focused right now on getting the message out that to vulnerable communities that they should accept the vaccine, that people, there's a lot of fear about the vaccine, and as many as 30 to 40% of people are at this point not willing to take the vaccine. So a big point of emphasis right now is how to tackle that. How do we address the distrust of medicine right now in general, and to get people to accept the vaccine. That's probably our number one task right now, is getting people to is messaging. Mm-hmm. There are, of course, also a number of issues about distribution of the vaccine and so forth, but that single message, that single point about getting people to trust in medicine again. I mean, unfortunately, the past year, there's been a lot of disinformation and not not accepting science. And so the big point for us is to change that message to say that we're going to work off of science, and that you can trust the team.
Yeah, thank you for that, and I'm glad you're working on that nationally, and I know in California we're working on that as well. And so maybe I'll pivot over to you, Erica, not exactly that question, but you talked a little bit about the prioritization framework. Well, let me just start by saying, not unexpectedly, we have tons of detailed questions about vaccines from our audience today, and unfortunately, we won't have time to answer all of them. But what I will do is commit that we will come back here with another talk with a lot more time to discuss vaccines, because I know that's a big thing for everyone. But in the meantime, you talked about the prioritization framework, and I know that ACIP has a recommended one. Do you anticipate that this sequence that we're going to vaccinate here in California is going to be very widely from ACIP or vary at all? And then also someone was asking about how California is thinking about equity in vaccine distribution.
Sure, both great questions. So we've already approved our phase 1A, which again, as I mentioned, is healthcare workers and long-term care and skilled nursing facility staff and residents, very in aligned with the ACIP recommendations. What we do is then get that down to a much more nitty-gritty level, and we've our teams have done a lot of data collection to see, you know, how many are fitting into those different tiers, and so we can really look at that at a nitty-gritty level, and then of course at the local health department level, they will do the next layer of that. So we don't anticipate that we would vary from that, but we are going through a process of, in the drafting guidelines, of reviewing the ACIP and then just making sure there's agreement. And for the essential worker conversation in phase 1B, they are looking at 4 criteria right now, and even figuring out how, getting community advisory committee input on how they're going to rank the criteria. And that's a good segue to the other question, which is that equity is one of those criteria. I don't have my fingertips the other 3, but again, these are all being discussed at our public community advisory committee meetings, and then there will be posted summaries of that as well on what decisions are about priority, and then how they're going to look at these really tough questions that have been very discussed in the media as well, as far as, you know, who do we define as an essential worker? How do you prioritize those, especially in a state this big? So more to come on that. That's what the committees are working on very actively this week.
Thank you. And I apologize, there's some feedback coming from somewhere. We're trying to figure that out, but maybe in between questions with each of you, we can all try to mute ourselves. Next question I'd like to ask, maybe all 3 of you can comment on this. How effective do you think that California's measures, the lockdown in many places, will be this time compared to this spring? It's a really scary time in many ways. We look at those curves, they're quite dramatic. How hopeful are you that we'll be able to flatten the curve maybe by the new year? And what are the factors that are impacting that as you think about it?
I'd say hopeful. We have to be hopeful. We have to be hopeful. I defer, of course, to Dr. Phan, but I think that there's been I think I'm getting feedback too. There has been an incredible amount of thought gone into sort of everything that's come into play. And I think that's one of the reasons I wanted to actually spend some time on the data and think about our own roles. You know, when I see patients and I do Zoom clinic, and, you know, and I'm talking to them about a mycobacterial fortuitum, you know, I ask them how they get their groceries. So I think, you know, like so many things, we actually have a role, and there's been a lot of data, you know, to Dr. Rodriguez's point too, is when physicians talk about these things, whether it's the mental health effects or the masks or trying to figure out how to mitigate your risk, you know, whether it's, you know, being pre-contemplative about, you know, quitting cigarettes or whatever it is, all these things that we've learned over time, these remain important tools we have, actually. We have a lot of power in that way. So I think, you know, from Dr. Phan and our kind of team, you know, we're very thoughtful and understand how challenging this is. And, you know, anecdotally, I will share with you, I walked into my hair salon on Saturday and I had to answer a lot of questions. And it was hard, but we talked about it. And that's, you know, every moment is a teaching moment. And let me tell you, they teach me too. And so, you know, that's what we have to do. And I think this is where we were at. Dr. Phan, I defer to you, but this is where we're at. Not much of a choice here.
Yeah, no, thanks. It's, it is the toughest question that we've grappled with through this entire pandemic. And as far as between March and now, of course, the huge differences are we had, so many fewer cases in March, and it was a brand new thing, and everybody was concerned. And I think, there really was excellent sort of compliance. I think the vast majority of people really did stay home. The businesses were closed, and boy, did we flatten that curve. And that's what we have to keep reminding people, that we did it, right? California flattened that curve. We did so much better than all the other states because we did it early, and we didn't have like a first wave. I was actually just looking at some other national, all the other national curves have a third bump, and we don't have it because we stayed at home, we sheltered the first time. I think, now that I have moved from a local to a state level, I have a whole new appreciation of the diversity of this state and how much, it is really unfortunate. There's just to Dr. Rodriguez's point about misinformation, and people don't want to hear the science anymore, or they want to hear how the science will best fit their situation. So I do think, we're very worried about pandemic fatigue, and we know this is really hard for people to do right now. And we did try to use science to guide us on really moving everything we could outdoors. We really tried to, our sort of purple tier in California is much stricter than most other states' dial back or pauses, and we still were not making any kind of dent in this huge trajectory that Seema was showing you of cases and hospitalizations. So I am optimistic it will work. I think I'm concerned that it won't. Certainly, compliance is not going to be like it was in March, but I think even if a huge percentage of people, and we'll be continuing to work with our modeling team that Dr. Jane is leading now to be looking at this, but that we can at least make a dent so that we can hopefully not move to crisis standards of care. I mean, that is of course our biggest concern, not only this physician burnout and all clinical staffing burnout, which is, we're there already with that. And then if we really overwhelm and have to be sharing ventilators or, using these alternate care sites without enough staff, we just don't have enough staff. And then of course we're trying to prevent the deaths. But I do think the public has become a bit numb to this. And if it's not real, it's really not, so I have concerns. I live in the Bay Area, and I think there's a lot of compliance in the Bay Area, but I think throughout the state, that is not necessarily the case. So I do hope people are listening, and that you all as clinicians can really talk to your patients about this as well, and know that we tried to do everything else that we could, and we really, we did come to this point where we weren't making an impact, and this is why we are where we are now.
Thank you. Yeah, I mean, it feels a little bit hopeful that we can all do this. Rob, yes.
So I'm optimistic as well. I think that both Drs. Jane and Dr. Phan made excellent points about all this. I think that I'm optimistic to the point where, but I also would, for all the listeners out there, again, to Dr. John's point about you need to tell your patients that now's not the time to let up. I think that there may be. I'm a little concerned that people are thinking, oh, well, the vaccine's on its way. This is going to all be over with, and but no, it's not. It's not going to be over with. The risk is still going to be very, very real, and so I think it's critically important for physicians, for everybody to get the message to your patients that you need to continue with your masks and social distancing and everything else, and so and don't let up.
Yeah, important messages, and I think hard for a lot of people to hear, but we do, we're in for a tough one if we don't do that. So I think we hopefully have time for one more question. And Rob, I'm just curious if you wouldn't mind, or you have any lessons learned from the time you spent in Brownsville, Texas, caring for populations there.
Yeah, thanks for that. It was, this is the lesson that I learned. It's that it's a totally different ballgame in other parts of the country. We in the Bay Area and really for most of California, I would say, are very fortunate to have adequate resources in terms of hospital beds, but more importantly in terms of staff physicians, nurses, and respiratory therapists. I've always said that if we do have a surge here in the Bay Area, we have at least 300, maybe up to 500 docs, critical care docs, emergency physicians, other practice type inpatient in hospitalists and others who could help with the surge. When I went down to my hometown of Brownsville, in the hospital where I was born, it was tragic. We were overrun. There were no beds for anybody. We ran out of meds. We didn't have the standard meds that we would typically use in the ICU. I was put straight to work in a COVID ICU, and out of necessity, I was put in charge of a unit without ever having really even met the rest of the staff. It was just the resources down there were just so different from up here. Brownsville's is the second poorest area in the country, and per capita, and it's just it was a real challenge, and I think that the message for California and for other areas is that that you also got to think. You shouldn't just think locally. We should consider supporting other areas of the country that don't have the resources that we have.
Those are hard stories to hear, and I think it does bring back the point, as Erica said, that we're really lucky to live in an area of high compliance, and I'm super grateful to you and all the other doctors who are working out there in a variety of places. We are still awaiting Dr. Guzby. So I have one other question for you, Dr. Pond. Where will the independent and small office healthcare providers be able to get vaccine in the early stages of the rollout? And how about small frontline providers like the hospice agency, for example? There must be, the devil is in the details here, right?
Yes, and those different providers are definitely in the different tiers, and I think as we sort of get through the tiers, there's going to be more and wider distribution. I think certainly sort of individual providers who have their own healthcare would be able to go to their healthcare provider, right? So it's still going to be centralized through our healthcare system, and so I think the devil is absolutely in the details as far as making sure people meet criteria when we have a scarce resource, right? So I think during H1N1, it was still not quite this much of a trickle, and yet there were mass vaccination clinics with those first very large shipments, and even though really like a county clinic was meant to be for county residents, there was not a lot of, oh, I'm going to check your ID and turn you away. So I think it is going to be more challenging on the front lines of those of you actually who are providing the vaccine to try to uphold the prioritization, and it is tough. And on the other hand, some of the principles there, and speaking to some of our more rural areas or other difficult areas that we're trying to also have them regionally collaborate and bring people together. There's nitty-gritty logistics, like the Pfizer vaccine comes in these, they call them pizza boxes, and there's 975 in one sort of box, and you have to use all of those within 5 days outside of the ultra cold. And so we don't want to waste any vaccine, right? That would be much worse to move through the tiers. So there are some principles like that we're passing on that everyone should be aware of, that absolutely we want to follow these criteria as best we can and continue to move through the tiers of priorities, but absolutely we don't want to waste any vaccine during such a scarce resource time. So I think those are the different mechanisms of how that would work.
Great, thanks. And it looks like we're still having some technical difficulties to get Dr. Guzby on. So I have another question, Seema, for you. who should be getting tested with expanded respiratory panels for influenza and COVID and any of those other viruses? Should anything else be in the panel this winter as we're sort of going through what is usually flu season?
Great question. I love that question. There's something in the chat that says that Eric is in the waiting room, just so you know. I don't know what that means, but Alice wrote it. Yes, so I mean, I think it's a hard question. I mean, I'll be very honest. I've been on a couple of panels, including IDSA, and there's an upcoming ATS PICO guideline as well coming out about this. And, you know, I'm always the public health person who wants to test everyone because I know that if you look, you will find. However, that isn't exactly what the guidelines say. So there is a guidance that was led by Kimberly Hansen from University of Utah through that you can find in CID, clinical infectious diseases, that is, and really focuses on who you should be testing for. It really actually focuses on flu, actually, and other respiratory viruses for which you can do something. So let's just remember for flu, you know, we do have antiviral treatments. We do have a vaccine. It's not too late to remind your patients to get influenza vaccine. And so those are a couple of things to remember. Most of the guidances, including the pneumonia guidances from IDSA and ATS, really recommend for testing of other respiratory pathogens in the setting of really sicker patients, either hospitalized or in the ICU. That being said, you know, I think, you know, from a public health perspective, this is one of the reasons why we have set up outpatient sentinel surveillance systems, because it doesn't necessarily make sense to test every outpatient. Some of these respiratory viral panels are really expensive. The BioFire is not cheap. And so, you know, we do need to think about our resources as well. And that's where these sentinel surveillance systems, I think, have a lot of value. And clinically, I would say, you know, we have flu, but we also have other respiratory viruses. And maybe just to back up for 1 minute, previous pneumonia etiology studies used to show, some published in 2015 by myself, have really shown that in general, it's really kids who have a lot of co-infections specifically. So about 25% of kids shed multiple viruses. And just for those, you know, out there, you know, you can't really anecdotally from a syndromic or clinical standpoint tell the difference between one virus or the other, or look at a pneumonia pattern and say, hey, there you go. It just doesn't work that way. And in adults, it's about 5%. And I think that that's one of the reasons we really wanted to set up sentinel surveillance at the community level, because we don't know yet. There are conflicting data out there about COVID specifically, which show actually a higher proportion of adults having co-infections. And then also, what does that mean exactly? And I think these are really important things to monitor because, yes, we have non-pharmaceutical interventions. We got pandemic fatigue. We have a vaccine coming out. Well, we don't know how COVID-19 is going to fit into the seasonal paradigm of viruses. And so there's a lot of questions, at least that I have, around this. And then one thing we didn't talk about that I do want to just make sure that we don't forget is that we haven't talked about bacterial etiologies of respiratory illness, including pneumonia. So also for your patients, don't forget pneumovax and pneumococcal vaccines as well.
Great, thank you. It seems like we need to schedule more time with you, Dr. Jane, because you have lots of expertise in this area. I am very happy, however, to now welcome on Dr. Eric Goosby, who was here a minute ago, and now I'm not seeing, so maybe we won't recommend him on. Seems that we're having some technical difficulties with Dr. Goosby. Dr. Goosby, are you here? Can you hear me? Seems like that is a no. All right. Oh, there, yay. Oh no, that's just his picture. Okay. I'm going to tell you that once we can find him, our final presenter today will be Dr. Eric Goosby, who is, I've already detailed some of his amazing accomplishments, and it would take too long for me to go through them all, but he is currently a professor of medicine at the University of California at San Francisco. It seems that we don't yet, we do maybe have him online. It seems like he's on. So someone on my team can maybe help me, just let me know if Dr. Goosby's joining us. If not, we'll bring back Erica for another question about rolling out vaccines. And apologies for the technical difficulties. Okay. Dr. Bond, are you there? Can you join me for one more minute? We'll do another vaccine question because we have lots and lots of those. All right. I don't have any panelists here with me. Maybe Dr. Gusby. Oh, there's Dr. Jane. Dr. Gusby, are you here with us? It looks like you're muted, but here, maybe not seeing you. What I was going to ask, and maybe Dr. Jane, if there's any, a lot of people are asking if there's any timeline in which we expect to have data on pediatric vaccines and vaccines for pregnant and breastfeeding women.
Sorry, I needed to unmute myself. I can't tell you the exact timeline myself. I'd have to look at the ACIP guidance, but my understanding from the things that I have seen is that obviously we have this first pass with adults. I think children are going to be a little later on because I don't think that the trials in children have been at the level they need to be at yet. I have seen some information around pregnancy, but I can't tell you the exact timeline. I'm not sure. The big focus at this first moment is really the push for healthcare workers in long-term care facilities. The ACIP is meeting on Friday, and then again on December 13th, I believe. So we have a couple of back-to-back meetings, and I think each time they meet, they kind of grapple with the one question that they need to deal with. And so I'm expecting that there'll be several iterations of this on the days to come.
Great. And let me see, Dr. Rodriguez, can we bring you back in for one more question? Thank you. So we had a question about whether, it was a specific question about whether you foresee the Biden-Harris team adding a nurse to the task force. And it brings up a bigger question for me, which is, how do you as a task force think about what voices you may be missing among your group, and how will you and the administration think about reaching out to get a diversity of opinions and expertise as you do this important work?
Yes, they actually did. This past week, earlier this week, add 3 new members, one of whom is a nurse, and as well as another epidemiologist and another physician in I think in a Native American, working in I think in the Navajo Nation right now. So yes, they definitely are looking to broaden the input, and nursing is especially necessary. Nursing input is especially necessary, and they have responded to that.
Great. Thank you for that.
Another way for me to get you unmuted. There should have been a little box that pops out.
Yeah, I just clicked it. I just clicked unmute.
Oh, we've got Dr. Gusby. Dr. Gusby, we can hear you.
And I clicked unmute.
Welcome.
I don't seem to be.
Okay.
Dr. Gusby, we can hear you now.
Good. Okay.
So we need to
Get off the line, huh? Okay. Thanks for checking in.
Lovely to hear you, Dr. Gusby. This may be a little confusing, but there is a little thing that it looks like a camera. If you can click on that, we can see you, but we do have a lovely picture of you here with us today. And so I just want to welcome you very much to our conversation today. I know you've had a very busy day already. There you are. You did it.
What a day, honestly.
What a day.
My apologies.
What a month, what a year.
Yeah, okay.
So we'll take a big deep breath in honor
Yes,
of our wellness. And hope that technical details don't befuddle us too much. but I've already introduced you at great length. And so perhaps you can just give us a few words about anything you'd like to share with us. We're so grateful for your time.
Well, thanks, Kimberly and Alice. It's an honor really to be able to talk to this group who gets up and does it every day. So I really want to thank you for the commitment that reflects. I was asked to go on to the advisory committee for COVID to, I believe, help keep a, my experience really, I think that is added to the group of advisors is the understanding of how delivery systems at national, state, and local levels shuffle together to both plan and implement programs. And I include budgets that have to shuffle together to do that. The lack of a federal plan created a impetus for 50 different versions of response, and then within each state, all of the major cities and counties having their own kind of homologous reflection of that need, and created congestion and roadblocks all over procurement distribution, as well as planning and kind of collegial sharing of human resources. And I hope that we will be able to bring that kind of practical clarity to the prioritization and decision making that's going on. I feel that our awareness of what you are in front of and our ability to be responsive to that continues to be dependent on our personal experiences more than what they're bringing to the advisory board. So I would say that understanding things that become clear to you as you move through this response would be of high interest for us to try to, on a planning level, but also on a harmonizing, with a harmonization as a goal, we would want to take that back up for discussion. Right now, the processes that are in place to bring new concerns and ideas into discussion for the President and Vice President-elect consideration, this is really what this process is. So I would really encourage all of you to take advantage of that. Our focus now is looking at the vaccine rollout, understanding what the Trump administration has done specifically state by state as it moves to local sites, how they have engaged this process, and we are just beginning to uncover a state by state plan that they are saying that they have done for all 50. I think that our hope is that this COVID insult, as it came out with us, where we were in front of it and had to respond, will give us insights in kind of looking kind of in the post-vaccination fury, looking at the relationship between the public health system, the private sector, and the outcomes that we were able to create with this effort. And hopefully have discussions about what types of relationships would improve our ability the next time we're put a public health response, and pull us all out of our respective silos and funding relationships with private party payers and public sector, how that all comes together. The public insult that COVID presented caused all of us to realize that we haven't defined and built that space between kind of islands of excellence in hospital clinic delivery systems. And so I'm anxious to see that pivot as well. And the Biden-Harris President VP-elect are anxious and open to that discussion. So let me be quiet and just open up for questions.
Thank you for that perspective, and it's really wonderful to have you on that team. You talked a lot about how we sort of take those silos and put them together, how we make public-private partnerships. Maybe you can talk about how you imagine something very specific might change, like, for example, our national testing strategy. What might that look like going forward under that new paradigm?
Well, we feel that it has been underutilized. It is desperately needed to understand community spread. Instead of just looking at community spread, we need to map it. And to begin to map that, we need to start testing people who are not symptomatic with COVID. So our understanding of how many asymptomatics are out there, their role in transmission is large, 30 to 50% when you look at it. I feel not having a strategy to identify asymptomatics is a major deficit in our response, and we will not be able to get in front of the movement of the virus into the population until we understand how to identify asymptomatics and case find and manage around them. When that starts, that will require a doubling at least of testing capability now, and a home testing component is going to be critical for it to work. We have seen examples of that in the White House, in military efforts that are engaged in combat efforts. They do a 2-time-a-week testing protocol. We've seen it in basketball and football teams. Those that were doing once a week didn't really contain. Those that took it into 2 or more a week were, after 3 or 4 weeks and looking at trends, both in individuals and the group, they've been able to manage much better. Still occasional outbreak, but when it breaks, they can contain it. So it's that testing concomitant with the case finding that is responsive within a 2 to 3 day period is really the goal of this. In an exponential growth period in the surge, it is not possible to put case finding, contact tracing in place. It doesn't play the role it should play. So we need to push that total area under the curve down so we can regain control on that end. But then it's the same things. The other that we're focused on, Kim, is what will be a month delay from the first immunization, assuming it's Pfizer with a 21-day repeat for 2, and then waiting for a 7 to 14-day period after that to assume that the immune response is in place. So looking at 31 days where we're not going to be any different for this group of providers is going to be important to keep that in mind, in that we're looking at this for 4 months for sure. Herd immunity isn't until 6 to 9 months down the road where you start to reach 40 or 50% of the population. But before you reach 70%, we're looking late year, and we're looking into the next year, mid to late. I just think realistically. So we get a lot of questions about that over and over again, but yeah.
Thank you for that. And that timeline is really important to re-emphasize for a lot of settings. So, one of the places where we've seen some success in the sort of surveillance type testing that you've talked about is actually in schools, an area near and dear to my heart as I try to survive and have my kids thrive at home. And I would love to hear how you and the task force are thinking about addressing the increasingly urgent public health crisis of our nation's children's health and the wellness that's caused by school closures.
Well, you and every pediatric association society has shared the frustration around this kind of dilemma. and labor unions have around teachers, custodial staff, people in the cafeterias have been very in front of expressing their concerns around it to the advisory board. And the Biden-Harris intention is to look at every way to create a protective and safe environment in the schools. They are completely aware of the threat this has to children and in the deceleration of their learning. And the difficulty in making up for it is what's even more of concern, in that it's almost like a critical period. That if it doesn't come on board, you kind of don't get another clean shot at it, which I know for myself, I did not think of it that way. But everyone's convinced of that. But at the same time, feel we are smart enough to be able to create a safe environment. We need to be able to pay for it. And that convergence of the resources to create the environment and for us to test it out should have already happened in the last 7-8 months, and we should not be guessing at this, but we are going to be guessing at it for a while until we can get the data to map it out. But I believe everyone feels it's urgent enough that we should move forward in real time, but as safely as we can do it. So that's kind of the position. There's a commitment to move it.
Great. It's fantastic to hear. I have a question that may not be exactly in your area of expertise, though it may, but I'm curious what your thoughts are. We've now documented, last I saw, nearly 16 million cases of COVID-19 in the US. And given how many cases people think are asymptomatic or undiagnosed, I've heard some experts suggest that perhaps we're approaching 100 million people having been infected, which is nearly a third of all Americans. Curious what your thoughts are about those numbers, but if we're not recommending serology testing before vaccination, that's what I hear is being recommended. Given that high prevalence, would it be worthwhile? And then specifically, as we vaccinate healthcare providers, and again, if this isn't your expertise, that's fine, but how do we think about healthcare providers who know that they have serological testing that suggests they have indeed had coronavirus?
No one really knows the answer to this, but there's been a lot of discussion about it, especially providers who have had COVID. Do they need to be vaccinated again? There will be formal kind of discussions about it and recommendations. It is generally leaning toward, yes, they should be vaccinated again. And then they go into, well, should you do the 2 vaccination or just do 1 vaccination? We don't have the data to really speak to it yet, but there are people who are very interested in mapping it out. But I think the recommendation out of default will be the risk to you in being vaccinated on top of an immune response that is already mounted is such that this vaccination is probably the smarter way to go. That'll be a formal recommendation, though. There will be one. Yeah.
Great. And finally, a personal question that you can absolutely deny to answer. My patients do this all the time. They say, doctor, what would you do? So Dr. Goosby, are you going to get a vaccine? And if you had a choice, which one would you get? And you can plead the fifth on this if you like.
Yes, I would. And I would get the first one that is made available to me. Okay,
great.
so that's a shorter than you wanted me to answer, but I think it's fair for people to ask their providers what would they do, and you can go through the risk-benefit discussion. You can go through the 2-dose, the single dose, the mRNA versus a virus vector. They all are so good. You're kind of, in terms of if efficacy and safety are similar, which it looks like the first 3 are, and if efficacy's in the 93 plus, 95, 96%, I don't believe you need to worry about that. And if there are idiosyncratic or comorbidities that might make one thing less safe for you in terms of an allergy history, I would react to that, but nothing nothing really that I would put out there as a kind of approach to which vaccine you should take. It'd kind of be a waste. I think it would be a waste of time if people started to do that.
Yeah.
You know, which one is the best one for me?
I agree. And one final question, this is just a clarification actually, but I'll use it as your way out. Someone asked it clarified if you mean we will obtain herd immunity from these vaccines towards the end of 21 or 22. I'm hoping you meant 21. And if so, is that when you think we'll be able to go to large events and stop wearing masks?
I believe that, you know, you'll start just looking at other viruses. HIV in particular, we, you know, really used herd immunity, the idea of it, and looked at it everywhere. We basically scaled up in sub-Saharan Africa. In that virus, you see a flattening of the number of new seroconversions at about 30 to 40% of the people who are indeed with HIV in the community. As it moves into 70%, you kind of see transmission drop way off. And the herd immunity pattern that we're kind of using as the goal is that 70% mark, but who knows, you know, we'll see. I think timing wise, the convergence of the people who get infected you know, from an exposure, and then the addition of the vaccinated individuals, the modeling really shows at the end of the year of 21, and that we will be able to return to congregate activity. Almost certainly is the belief. Now, everyone is hesitant to say this is absolutely what's going to happen, but I believe it is. I think I'm optimistic, and you know, talking to Tony Fauci a lot about this. You know, you're talking to people who have a collective experience but no data. It's really the feel is that we should be able to think in terms of returning, and I know that hope is important now.
Great. Well, unfortunately, we're over our time. I could talk to you all day, and I really could not be more grateful to you, Dr. Goosby, to Seema, Erica, and Robert as well, for all of your service that you're doing in this really important time, and also for presenting with us today. And I also want to thank everyone who's listening in today for bearing with us during some technical issues and some awkwardness, but I think we've got some great information, and we look forward to seeing you next month, Tuesday, January 19th from 12 to 1:30, and you can register for our next one at covidroundca.com. I just also want to point out that CMA does provide amazing webinars and resources on the CMA Telehealth Tipping Point Project, and you can find additional information on that at cmadocs.org/telehealth webinars. Just a reminder, you will be sent a survey around 4 o'clock today where you can attest to attendance, and that's how you get your CME. And do send the information on this to your friends and colleagues, because it will be recorded and posted on our website very soon. So thank you again, Dr. Goosby, and all of the rest of our speakers who were here today.
Thank you.
Thank you.